Hello and good evening and welcome to the latest in the series of the hashtag GP Together live presentations. My name's Dr. Gary Howsam. I'm the Vice Chair for External Affairs at the RCGP, and I'm delighted to be able to be speaking to you along with some colleagues on the panel about social prescribing in the wake of the pandemic. If you have any questions you'd like to put to us, if you go onto hashtag Team GP Live on social media or through the RCGP Members Forum, then we've got members of our team looking for those questions that we can put to the people on the panel. So if you've not seen one of these presentations before, the aim is for us to be able to speak to you as members and leaders at the college about some of the activities that we get up to that maybe you haven't heard about previously. So on to the topic, social prescribing. What is it? We'll be getting into a bit about its history, its role now, and its importance for the future of healthcare. For the college, social prescribing is being pioneered by some practices who are seeking to tackle patient health inequalities and problems more holistically. In our 2018 Loneliness Manifesto, we talked about how caring for people and about listening and understanding their concerns, asking what matters to you rather than what's the matter with you, could transform the type of care that people are identifying they needed and the type of care we are able to give them. Quite often, patients' problems lie out with our gift as doctors and healthcare workers to facilitate a solution. So this is where the role of social prescribing has been expanding and becoming much more important. 2 years on from our Loneliness Manifesto, the college is still focusing on relationship-based care and the really important role that social prescribing can take in that. How are we going to improve services to our patients? How are we going to improve the care that we can offer people? And how can we empower people to look after their needs in the broadest sense when it comes to the wider determinants of health and that's health and well-being? However, the pandemic's changed everything. Or has it? Is social prescribing still relevant? Has it become totally irrelevant? Is it an area that we'll still be funding? These are the sort of areas that I hope we'll be looking at this evening. That's probably enough from me for now. What I'd like to do is go around and introduce the members of the panel. I'll very briefly introduce them by first name, and then if I could ask each of them to tell us who they are, where they work, why they're on the panel tonight, and maybe what their definition of social prescribing is, because I'm not sure we'll get total agreement from everyone on exactly what we mean. So if I can start with you, John, thank you very much.
Hi Gary, so my name's John McGuinness. I'm a first 5 GP in Lewisham, South East London. I'm currently coming towards the end of a Darcy Fellowship with King's Health Partners. I also work with the RCGP as a clinical champion for the Social Prescribing Observatory. So for me, social prescribing is a way of addressing a patient's non-medical needs and the wider determinants of health. And it's about connecting these patients into community assets, so that's local community organisations, exercise classes, and for the voluntary sector to improve their health and well-being.
Excellent. Thank you very much, John. Perhaps we can go over to you, Anand, please.
Thanks, Gary. My name is Anand. I'm an Oxford Martin Fellow at the Oxford Martin School, University of Oxford, and I'm working with John and Debbie Ann on the Social Prescribing Observatory project. And for me, I would take basically what John said in terms of his definition, which I thought was great. And I stress that what we're looking at is addressing social determinants of health and non-medical needs.
Excellent. Thank you very much, Anand. And over to you, Graham.
The old mute, finding it. Thank you very much. My name is Graham Kramer. I'm a GP in Edinburgh. I am RCGP Scotland's Executive Officer for the Patient Partnership and Practice Group, P3. But I have a leadership role in Scotland around sort of supporting the adoption and spread of care and support planning to Scottish general practice, which is really about how we empower, enable and support the self-management of people living with long-term conditions. And a key part of that is really identifying or helping patients to identify their own solutions to their needs. And then I guess social prescribing is working together to identify the support that they need for those needs and connecting people with that support. like many people, we don't perhaps like the term social prescribing because it isn't prescriptive. It's not about, I think you need to take more exercise, I'm going to refer you to the gym. It's very much the person themselves identifying what their needs are and what their solutions are.
Excellent. Thank you very much, Graham. And if we can go over to Debbie Ann, please.
Hi, thank you very much. My name is Debbie Ann. I'm a social prescribing link worker at One Health Lewisham. And I've been doing this since December, since the project started in Lewisham. I would say social prescribing is the bridge between traditional medicalized primary care and sort of the community sector, and looking at a holistic approach to well-being and to health. I would also say that, rather than us looking at, the symptoms and the very, medicalized sort of what's wrong with the person, it takes a person-centered approach and looks at the wider issues surrounding the person and the social determinants to health, and uses that to mitigate and solve almost and address problems that are important to the individual.
Excellent. Thank you, Debbie Ann. And over to Owen, please.
Hi, I'm Owen Richards. I chair the UK Patient and Carer Partnership Group for the college. My day job is working with a local health watch in Essex. And I love being put last because I think everyone has described and used the sort of words that I was going to use. So I'm afraid we're having a bit of a love-in to start already.
Okay, and you're not quite last, Owen, because I've saved the best for last, and I'm going to go over to Davina. So, Davina, if you could say hello, please.
Hi everyone, so I'm Davina Mara, I'm a GP registrar and I'm based in Greenwich, southeast London. So when I was a medical student, the College of Medicine, in collaboration with NHS England and the Social Prescribing Network, set up the National Social Prescribing Student Champion Scheme. So I was a student champion in the northwest of England and taught over 500 medical students about social prescribing. And now as a GP trainee, I continue the enthusiasm about social prescribing. So to me, social prescribing is basically enabling healthcare professionals to refer patients to a link worker who can then co-design a non-clinical social prescription to improve their health and well-being. So looking at the person as a patient and not medicalizing the model.
Excellent. Thank you all for those introductions, both to yourself, but also your ideas of what social prescribing means. One point I'd like to pick up on straight away is we talk about the wider determinants of health and how those impact on our patients. And of course, there's a political aspect to that as well. So in the time of a pandemic, when we know that the nation's economically weaker, the health service is potentially overrun, what makes social prescribing so important right now? And Ant, maybe I can ask you that question.
Thanks, Gary. I suppose if we almost immediately look to the most recent example we have of a shock to the system, we have the 2008 global financial collapse, which was a great example of something that really shook things up, not quite as much as COVID-19, but it shook things up quite a bit. And it took us about 4 or 5 years to recover, at least nominally from a GDP perspective, from the 2008 global financial collapse. A lot of joblessness, mental health burden, substance abuse, domestic abuse, etc. And obviously this has real huge ramifications for the future of any country. And I think from a political or economic perspective, what we can see is that these sorts of shock events lead to a lot of suffering for our citizens, and the root cause of the suffering will be within the social determinants. So if you look even at the best of times, social determinants, as we all know, will account for about 80 to 90% of health outcomes. Only 10 to 20% are actually due to clinical care. And so in a time of a pandemic or sort of a systemic or societal shock, they're going to be even more important. And this is where social prescriptions and social medicine generally are so important. And again, if we look historically, a lot of these ideas came from the Industrial Revolution around needing to look at these social factors related to health. So the first formal description of this came in 1848 from Rudolf Virchow in Germany during the Industrial Revolution, and some of the turbulent times that the citizens faced. And what they realized was that for the health of the population, what they needed to do was to address these social factors related to health. And I mean, I think social prescribing has a critical role to play in addressing these non-medical factors related to health.
Excellent. Thank you, Anand, for that answer. And I think it's probably fair to say that certainly in my practicing lifetime, I've not seen anything that has had such a massive impact on the whole of the population at one time. Perhaps I could come over to you, Owen, as a representative from the patient group for your take on why social prescribing is so important right now.
So I think if you just consider the relationship between a patient and a general practitioner, I mean, you are providing that cradle to grave service. So there's always a GP in someone's life. And I think what we've seen pre-COVID is a lot of patients thinking, I can take all my well-being issues to a general practitioner because that's the one constant, almost. You know, we don't all have a social worker. We, may not access other healthcare services, but we've all got a GP. That's the strength of what we have in this country. And if you think about someone like Sam, he's from Chinese heritage, he's in his 40s, he's been working from home, but actually he really hates it because he feels so isolated. He also knows his job is at risk. One of the good things about his employer is that he's been funding some ongoing education and training for him. He lives in rented accommodation, but it's not brilliant and it's not helping his health because of his respiratory problems. I mentioned that he was Chinese because he's also getting some abuse when he goes out to do his shopping because he's Chinese. And isn't that where the virus started? So didn't you bring it over here? Now, if you think of someone like that, and I know that's an extreme picture in a way, although part of it isn't, that's where people are going to be looking for so much more support. And at a time when general practice is under so much pressure, because we've got clinicians who are shielding, they may be ill themselves and may not be able to work, we have to think about different ways in which we can address some of those needs that Anand's already described. So I think it's absolutely critical now, as it always has been, that we can do more to help people find alternative sources of support around their well-being issues.
Excellent, thank you, Owen. And I think, as ever, bringing in a patient's story, whether it's one based on truth or a fictional one like that, is really powerful. Debbie Ann, I'd like to come over to you next, please, to first of all get your take on why social prescribing is so important right now. But then maybe a follow-up question after that would be to ask you what role you've been playing during the pandemic. But if we can just start with what makes social prescribing so important right now for you as a link worker?
Yes, so social prescribing right now, I would say, is really important because of so many factors that some have been mentioned before. But loneliness and social isolation, I would say, is a big issue that we have been dealing with. And we see, and I've seen certainly in my work with One Health Lewisham, a lot of our referrals have been for loneliness and social isolation. So I would say that, especially during the pandemic, where there's lockdowns and there's different areas where socializing has kind of been restricted, especially where socializing has been restricted, but it's become more digitalized, and there's so many people who can't access digital technologies. So that has really created such a bar and barrier for many people. So I would say it's so important for people to be able to be given the access to socializing and to get support to combat loneliness and social isolation.
Okay, that's a great answer, and thank you for that. And can you just describe perhaps what your role's been during the pandemic? You say you started late last year, so I guess you're still fairly new into the role, but have you seen it change? Has it been what you expected?
Yeah, it's changed a lot, actually, even through this short period of time. At the beginning, it was more one-to-one and face-to-face, and you really had the time to go through with the service user, with the person involved, and go through their issues and really support them on a more personal level and on a more just well connected level. During the pandemic, obviously, because of social distancing, a lot of our support has been more remote, and it's been very, very helpful. And we've had a lot of, case studies that have said that it has been helpful, but it's been a lot more distanced. So over the telephone, over Zoom, over other digital technologies. And as well, during the height of the pandemic, where our role was very referral based, we were more on an outreach approach where we spoke to a lot of vulnerable people, had a list of vulnerable patients within the borough, and actually reached out to them to find out if they were okay during the lockdown. So our approach to social prescribing was more outreach and checking if everyone was okay. And then we did receive a lot of self-referrals to our service through that way, where it was traditionally through the GP. And it's gone through so many changes through this time, but it's still been very important, I would say.
Excellent, and thank you for that. I mean, I know certainly within my practice that the link worker we've had played an absolutely pivotal role in looking after the shielded patients, and has been a truly valued member of the team for that particular role. I'd like to go over to Graham, if I may, and Graham, ask you the same question of what role you think social prescribing or link workers have played in the pandemic. Particularly, I know that you're the clinical lead for the House of Care project up in Scotland, so that's maybe an angle you could bring into your answer, please.
Yeah, it's really interesting. I mean, there's been fascinating with the pandemic. I mean, obviously, needs have completely changed. People's needs and identifying those needs has been really important for us in practice, and links workers as well. But what's been sort of quite heartwarming in a way is that there's been a massive amount of community responsiveness during the pandemic, whether people have been home and noticing their neighbours more, and all these sort of local Facebook groups and WhatsApp groups that are set up to try and support each other, and I think that really has been heartwarming. And whilst horrible stories of people's mental health and deteriorating, and the loneliness, and I have one patient actually come and say her mental health has improved because she's found a new purpose in life for supporting people around her, which has been really fascinating. But I think the key sort of change for us in general practice and the way we work is really just sort of harvesting these completely changed needs, and I suppose and how we respond to those needs, how we connect people who are now going through sort of mental hardship or domestic abuse and substance misuse and all these other sort of things that Anna was saying at the beginning that disasters cause. So it's a really complex change landscape, and we're all sort of trying to respond to that. And I think the links workers have been fantastic, because not only have they been connecting people up to the communities, but they've been it's the reverse. They're helping the communities and patients connect with general practice, which has been really, really important as well.
Excellent. Thank you for that, Graham. We've actually had a question in from someone who's watching on YouTube, a question from Richard, who's saying, we've had a few social prescribers leave recently, probably because they've not been doing the job they're employed to do due to the pandemic. Have others found the same? So we've heard from Debbie Ann about how flexible she's been and how her roles change. And Graham, you've talked about how the needs have changed. John, perhaps I could ask you, have you found in your area or through the work that you do that we've noticed there has been a fall off in the number of social prescribers because they've left the role because perhaps it hasn't been delivered in the way they thought it was going to be delivered, or hasn't been the role that they were expecting?
I think you're completely right, Gary. In terms of, there was a recent report by the National Association of Link Workers, and in their study they'd found that nearly up to 30% of link workers were either feeling burnt out, isolated, or considering leaving the profession, which is it's a real shame. It's a real worry for us. I think we know that link working works best when they join a team and they become part of our primary care team, and we embed them in the MDT. And we know that they need to be supported, and they need to have their education and training needs met. They need to have, mentorship and be linked into other link workers. And I think that's really important. There's been stories of link workers who joined a team, haven't had the right tools, in terms of phones, laptops, haven't had access to the electronic health records. And that is all integral for social prescribing to be a success. And there's been an excellent report from National Voices on rolling out social prescribing, and they identify some of these challenges. But yeah, it's we need to do more to support our link workers and make them flourish in the areas where we're based.
Yeah, absolutely. And I mean, for me, it's no less true for link workers than it is for any other member of the team that we're introducing into the primary care team. And for those that have come in at the start of the pandemic and have been working in more remote or isolated ways, it must have been very difficult. I'd just like to spin that round, and I'm going to come to you, Davina, in a moment to answer this question. But I think you've probably found as a GP trainer yourself, you're dealing with patients in a very different way, often using new technologies and more remotely. And patients on the whole have been really quite accepting of that, because they've understood the reasons for why we did it, in order to keep them safe, in order to triage and reduce footfall through the surgeries. But do you think that patients will tolerate this method for delivering social prescriptions and consultations with link workers in the future? Or do you think that they will want to get back to the way it was done pre-pandemic? Have you got a view on that?
So as a trainee in general practice currently, you quickly work out that the traditional options of a medical tablet might only have a limited impact if, for example, poor housing, finance, or employment issues are impacting the patient's emotions. So it's even been estimated that around 20% of patients consult their GP for what is primarily a social problem. And in fact, the Low Commission reported that 15% of GP visits were social welfare advice. So I think patients will appreciate having a social prescription where we can start treating and helping them with anything like poor housing, low self-esteem, isolation, because that's really what they've come in for. So I think it's the new 21st century way of treating a patient.
Excellent, thank you for that. And I think we're at a bit of a turning point, aren't we, within the profession, that both the clinicians but also the people that we're here to look after are willing to adapt and adopt to new ways of receiving care. So maybe this is a sweet spot for really embedding social prescribing into the options that we can give people. One of the other questions that springs to mind is that obviously this is really important if we're going to integrate link workers and social prescribers within our teams, that we really understand what value they can add. So in a minute, I'd like to talk about how we get training changed for us as doctors so that we appreciate the role of these other folk. But first of all, Anand, perhaps I can come to you to talk about how we measure how useful social prescribing is, because it sounds fantastic, but what's the evidence? Where's the proof?
Yeah, that's a great question, Gary. Thanks very much. Well, I mean, I think the first step is to disaggregate social prescribing, because asking about evidence for social prescribing is like asking evidence for pharmaceutical prescriptions. Some work, some don't. Some work for some people, some work for not other people, right? So it's going to be the same thing for social prescriptions. And like we have ICD-10, where we're able to actually disaggregate between different clinical areas, we need something similar for social prescribing as well, for different social needs. So as Davina was saying, is the individual coming to you with a finance problem or an employment problem or a substance abuse problem or a domestic abuse problem? And then from there, ideally what we should have is separate outcome sets, like you would, again, for sort of clinical medicine, right? If somebody comes in with AF, atrial fibrillation, you're not going to measure HbA1c. If they don't have type 2 diabetes, you're going to measure INR, TTR. So in the same case, you're going to need different outcome sets for different types of social needs. And the social prescriptions will also need different types of outputs and outcomes that you attribute to them. So in terms of building up the evidence base for social prescribing, I think the first thing we need to do is to ensure that we're recording and collecting data on social need, and then the exact social prescription that was given. And then as a community to come up with outcome sets that we would ideally want to deliver to anybody with a social need that can be attributed to a social prescription. I think the other key thing to think about here is just time. I think it's an unfair double standard to think that we can get all of this evidence for social prescriptions just like that. Pharmaceutical prescriptions have a 10-year runway and £1 billion before they're able to get into the marketplace. We don't have anywhere near that resource for social prescriptions as a modality of intervention. So I think we need to think long-term about this, and we need to take a 10, 15, 20-year perspective on building up the evidence base. It's not just consuming the evidence, but building up the evidence as well.
Okay, could you just very quickly, Anand, for me, you mentioned coding there when you were talking about different things. For some members of the audience, because this is going out through YouTube, might not know exactly what we mean by that. So could you just put that into real simple terms for us, please?
Sure. So as a GP, if I come to visit you and I come with a problem, you will have to have a way of recording that in your electronic health record. And you will record that with different codes. And those codes will then be captured in the electronic health record and will give people an indication of what was used, and it's also used for billing purposes and audit purposes as well.
Excellent, thank you. And I know when we were doing one of these talks the other day about research, the importance of coding in the medical records was stressed very strongly by Simon DeLucion, who works at the Research and Surveillance Centre, whose mantra is "coding is caring." That was my take home from that one. I know John's smiling because I know John works closely with Simon. And John, I will actually bring you in a moment to talk about your role with the RSC and the Social Prescribing Observatory, if I may. But if I can just go to Owen first, and I think you wanted to come in on that last question.
I mean, it was just really, I suppose, to follow up on Anand's point about the importance of co-design in looking at outcomes. So as well as the statistical stuff, it's also about the lived experience of the patient and how their lives have been changed. And of course, as Anand said, with any sort of public health type thing, there's a long time behind that. And it's how you track all of those patients through all the systems, and particularly in an area like London, where you've got such movement of patients. But I think it's really important that we try and capture the patient voice in all of this as well.
Yeah, and I think that patient voice is critical. From some of those definitions that you guys gave us earlier on, it was about self-identifying issues and helping the patient identify their needs and then sort of matching that to a solution that's going to fit them. So the patient voice and co-design seems to be absolutely critical component of this. You know, without that, I don't think it can have the impact that it would if those elements are there. So John, if I can go back over to you then, please. Perhaps you could just describe what the Research Surveillance Centre is and your role there, and how that's helping us understand the value of social prescribing, and I guess even really basic things like how much of it are we doing?
Thanks, Gary. Just before that, I think just to pick up on what Owen and Anand were saying, I think it is really important that we think about what evidence there is for social prescribing, and also whether we are measuring the right things. And typical academic research often would think about assessing things like GP attendance and maybe reducing ED attendance. And social prescribing has got some evidence of impacting on that. So, a small study in Merton in London, they managed to reduce GP attendance by 30%, A&E attendance by 50%, and mental health being improved by 80%, which I think is fantastic. But also, I think we should be thinking about looking at, say, connections or friendships, thinking about loneliness. So it's really important to think about the wider impact of social prescribing. And Owen, I completely agree that we need to bring patient voice, we need to co-design, and think about outcomes which are really important to our patients and our citizens. So to talk about the Social Prescribing Observatory, so through the RCGP RSC, we collect data from over 1,700 GP practices, of which covers about a population of 8 million patients. And we can look at the social prescribing activity across England. And this is a live, we get updates twice weekly. And if you search for the Social Prescribing Observatory on Google, I would encourage people to have a look at it, explore it. because what it does is it breaks it down by really interesting demographics. So we've got ethnicity, we've got index of multiple deprivation, we've got age, we've got region. And you can now look at the activity of social prescribing on an STP level. So you can start to get some trends and insights about social prescribing activity on where you are and benchmark that elsewhere in the country. So, for example, really interesting in Southeast London, we have a large Black Caribbean, Black African population. And then I can use the observatory to start to look at their referral rate to social prescribing. And I can see that in the Black population, the rates are lower than elsewhere in the country. And then that can trigger off a question, well, why is that? We know that this population's cohort can have poor health outcomes. I think it'd be really beneficial from social prescribing addressing wider determinants of health. Yet in Southeast London, that is not happening right now. And then we can start a discussion with commissioners or others about why is that. So yeah, I would encourage people on the panel and anyone watching to go and have a look and just explore it and get in contact with the team if you've got any feedback.
And I think we're seeing both on a research front and with the social prescribing observatory and the workload observatory, the power of having all these practices linked through the research surveillance centre that the RCGP runs. And again, just to echo what John said about going online and Googling the data, because it presents it in a really user-friendly type way. So definitely worth half an hour of your time to sort of plough through that. What I'm going to do is I think it's really important because we've talked about, okay, we've got some evidence that it works. We need to develop the research further. And that data, that information, that proof of impact is really important when it comes to sustainabilities of these projects, because someone's got to pay for it. So in a minute, I'm going to ask us to talk through the commissioning of these services. I know as a CCG chair myself that it's taken an awfully long time to get this far enough up the agenda and to try and find the evidence that it's money well spent. But before we do that, Debbie-Ann, I was wondering if I could just come to you. Maybe you could tell us about some of the impacts you've seen on the ground in Lambeth that maybe the audience wouldn't have thought of, that some of the different things you've been doing, and I don't know, maybe a couple of cases that have really landed with you that you think you've made a tremendous difference. That'd be really good to hear about.
Yeah, thank you. So in Lewisham, we have quite a deprived population. It's the 7th most deprived borough in London. And we know that obviously deprivation can lead to poorer health outcomes. And we've seen from what I've seen in my work with OHL, One Health Lewisham, is that social prescribing has been very helpful with those people involved and those people who have been referred. I have a case study of a man in his 50s who was struggling with his eyesight and had cataracts. He was waiting for an operation, but at the time he was homeless and sofa surfing with his friends. He didn't have recourse to public funds because of his immigration status. So those already are many factors involved in his health. So we worked together and found out what was going on, what was most important to him, his priorities, and referred him onto an organization, referred him onto Blind Aid actually, who supported him. And in supporting him, he was able to get a place to stay and to really move on with his life. Also had the operation, which went successfully with one eye as well. So, I mean, these are some of the examples of some of the victories with social prescribing and the impact sort of on the ground in Lewisham.
Okay, brilliant. That's great, Debbie-Ann. Thank you very much. I'm just going to park the funding and the commissioning element for a little bit longer, because I want to go back to Owen. And Owen, you're the lead for the patient and carers participation group at the college. And I know you spend a lot of time hearing the stories from all over the UK, from both patients and from carers. In your travels, who do you think benefits most from social prescribing that you can tell us about this evening?
So I think it is people like Debbie-Ann have just described, possibly the most vulnerable people in our communities. The ones who have that complex need, and the complexity isn't necessarily around their medical condition. They're presenting diagnosis to you as doctors. I also think it's about people who don't have the connections. And if you think about how society has changed over a number of years, when people perhaps didn't move far from their roots and they had that support network around them, you could always turn to someone for advice and support around that. Now, as we're much more mobile in terms of our lifestyles and our where we live, I wonder if we've lost some of those connections. And as I said, particularly if you think of some of the cities where people do tend to move around a lot, and they don't necessarily establish the roots, and they have those connections and know about the services that are available to support them. I wonder if those are the sorts of people we're really targeting. I mean, having said that, I think anyone can benefit from it, because so many of the conditions that people do come to you with do have those broader determinants in there. Some of them are clearly very medical things, but I also think there are those where there are other elements that come into play. And as I said, there isn't a BNF entry for everything that you'll come across. So I think it's actually potentially everyone who's out there.
Excellent. Thank you, Owen, for that. And one of the other questions I want to ask Debbie-Ann, you've given us a story about the sort of people you're helping and you're having an impact on. And I appreciate that you've only been in the job for a few months now, but do people have sort of a course of social prescribing and then that change is sustained? Do you think to send your patients have benefit that is longer than your initial intervention? Is that your experience on the ground?
Well, I would say it's quite difficult to say, because with social prescribing, because its importance lies in personalised care, I wouldn't. The cases are so diverse. They're really diverse. I wouldn't be able to say. So some people, you work with them, you speak to them once, and this is the solution, or this is what could help them, and they're good, and then they go. And others, you work with them throughout the duration of your time working with them, and they still may need some extra support. So it really is difficult to say. But I would say that there's a lot of people who aren't necessarily aware of what's going on around them and the support that is available. And social prescribing does really open that avenue up. So even with a particular issue, they may present a particular issue, but then when you discuss with them, it's so much more. And then you can talk to them about the support that is available. So even after your time with them has passed, they may be more aware of the voluntary sector, the community sector, and other organisations that are actually there in the community working and have been working and ready to support them at their need.
Excellent, thank you. Well, that's a great answer. What I want to look at now is based on a question that we've had in from Claire on YouTube. She's asking how social prescribing link workers are commissioned and funded in England. She says she works in Wales and there are small projects funded by the clusters. Although she mentions England in the question, I'm actually going to jump north of the border up to Graham, if I may. And Graham, what's your experience of how services are commissioned and funded up in Scotland?
Sorry, my space bar doesn't work for the sound. Yeah, so yeah, on the back, we had a sort of a links worker sort of pilot program, which was a collaboration with our alliance, which is the equivalent of National Voices in Scotland. It was a collaboration between them and Scottish Government, RCGP Scotland, and Deep End practices, and serving the most deprived practices in Scotland. And on it was very much a working program, and it really had some sort of encouraging findings really around the process, not so much the outcome, but the process. And on the back of that, Scottish Government in their manifesto pledged to fund 250 links workers to go into the most deprived practices in Scotland, and they've delivered that on that. So there's a broad range of links workers in these most deprived practices. Out with these deprived areas, I think there's a mixture, and I think there is some cluster funding of links workers, but also the sort of voluntary sector provide sort of signposters, and I know in some areas in Grampian and Aberdeen, for instance, these sort of have a mixture of health board and local council funding, and so practices can access their services in terms of helping move people on to more social support services that might be available locally, and they're real assets, and they do outreach into practice, so they almost sort of put a links worker into the practice and are there once a week to see people, which can be really, really helpful. So I think it's a sort of blended model that allows the availability of signposters and links workers to engage with practices.
Excellent, thank you for that, Graham. And certainly down in England, one of my other roles is I chair a clinical commissioning group, and I tried for a number of years to get social prescribers embedded within practices, and always struggled because the return on investment for every pound spent wasn't enough pounds back, which was a huge frustration. But of course, we've got the primary care networks in England now, and we get funding for additional staff, and lots of practices have chosen to spend that additional funding on links workers. So it's a really exciting time for us in England with a huge expansion on the number of people doing these important roles. So I mean, John, I don't know if you want to come in and talk about some of the challenges around sustainability and funding challenges that you've come across in your work, please.
Yeah, Gary, I think it was just a comment around social prescribing. Obviously, we're linking in patients into the voluntary community sector, but the real problem at the moment is that funding does not follow the patient. So on one hand, we're increasing demand because patients are being engaged in activities, but we know that capacity is a real problem, and it can't meet that demand. Particularly with COVID, a lot of charities are really suffering now in terms of their funding model. Having to lay off staff, they're reducing their activities, they've switched to online platforms. So, in terms of social prescribing being sustainable, we need to be more imaginative in how we're going to fund it, whether that's going to be through mixed model funding with the NHS, but also the local authority with the government departments. So, I think we need to be well aware of that we can't just push it all to the voluntary community sector and expect them to manage without our support.
Excellent. Okay, John, thank you. We've had another comment in from someone on YouTube saying, I'm a lead social prescriber. We have a team of 6 for our PCN. I feel it's so important to have supervision, continuous training, and to be involved in the surgery we work in. We're lucky because we've had all of these. And then they pose the question, following on from Owen's point, regards looking after the most vulnerable, likely digitally excluded. In the current context with largely remote consultations, how can social prescribers continue to best support those people? Maybe go to Debbie Ann for that one, around that last point, around how do we keep supporting the most vulnerable if they are digitally excluded, and that's the main media for connecting with patients at the current time.
Yeah, I think it is really difficult. The world has become increasingly reliant on digital technology, and we can all see it with this pandemic, like Zoom and Microsoft Teams and whatnot. And it does differ with the patient need. In terms of things like social isolation, there are telephone befriending services that are still running. So there is that. And I know in Lewisham, there is a certain service that uses recycled, like old laptops and old tablets and things like that, like a technology library for people who aren't able to access this themselves, whether it's due to lack of knowledge or lack of funds. And they do provide support in using these equipment. I know that it's not on a wide scale basis and not everyone can use that, but I think there is a step in the right direction. And we do have to look at ways of finding how to make technology more accessible to those who need it and who are locked away whilst we are relying on remote support.
Excellent. Thank you, Debbie Ann. I'm going to go over to Davina now because you've convinced me. Social prescribing is a great idea. We should all be doing it. We should find the money for it because it's having a good impact and we're doing the research to prove that it's all worthwhile. But how are we going to embed this into the curriculum so that trainees coming through into general practice, the GPs of the future, really understand both the evidence base and the value that this brings for their patients? I think you're a student champion in social prescribing, yes. Davina, was that right? Can you tell us a little bit about that, please?
Yes, that's a really great question, Gary. I think there is a huge appetite amongst trainees, and it most certainly should be incorporated into the curriculum, not only in the GP curriculum, but it should start all the way from medical school. It's a way of transforming medical education in this 21st century. So you're saying, what's the evidence of having it in the curriculum? What should we present to the educators? Well, social prescribing really does share the values that underpin the wider personalization movement in health and social care. And to fully address the social determinants of health, social prescribing schemes view a person not as a condition or disability, but quite simply as a person, which they try and tell you in medical school. Social prescribing was also listed as one of the 10 high impact actions in NHS England General Practice Forward Review. So that's why it should be also in the GP curriculum. We also learn in medical school about the Marmot Review, and that provided an analysis of the causes and consequences of health inequalities in England and factors contributing to the health inequalities like the financial issues that I discussed earlier, poor housing, low self-esteem. So it's important to incorporate it into the curriculum because people are living longer and struggling to cope and adapt to these living long-term conditions, and it can't be addressed by just a medical prescription alone. And now we are working in 21st century medicine, and another reason it should be incorporated into the curriculum is that it impacts on the economic impact, not just the social determinants of health. So more integration of primary care with the community can reduce the demand on stretched primary care services and reduce attendance referrals and has cost implications. So there's a variety of reasons it should be incorporated into the curriculum, and it should start from medical school and then onwards.
Excellent. And the passion you speak with, I'm sure, rubbed off when you were teaching those 500 medical students up in the Northeast you were telling us about earlier. So thank you for a great answer. I want to ask the question now about the funding and procurement, because it strikes me that if we're going to embed this in the curriculum and we think it's a great idea, you know, money's tight. As a CCG chair, I know we've got to work within an allocation of funds. So do we think this is good enough that we should be disinvesting in some, what we'd say is mainstream health interventions? And how are we going to go about doing that? How are we going to convince the acute sector that they don't need so much money to run hospitals because we want to pour it all into social prescribing? Graham, what's your take on that? And then maybe I'll go to Anant afterwards. Got the sticky space bar, but
it's terrible. Yeah, there we go. Yeah, no, I think this is a really crucial point. I mean, if we're identifying needs and we're trying to use those needs to inform our provision of social support to meet those needs, we have to find a way of funding it and sustaining it, and it's just vital. Otherwise, the whole thing collapses. And I think there could be potential for this. I mean, some of the work we've done is when we are helping people to identify their own solutions, and they often are not medical solutions. and they're more engaged in their healthcare, we actually find that the prescribing costs do drop for the same biomedical outcomes. People's blood pressure and sugar control gets better with less prescribing. And if we could release that prescribing saving, and if that could be shifted in any way to sustain support in the communities, that would be good. But there needs to be a huge amount of economic modelling around that, because that's going to be a big ask, because we're all sort of trying to be very protective about the funding that we get in healthcare. And it'll be a lot for us to accept that could go elsewhere.
Brilliant, thank you for that. And I'll go over to Anand, because I think we were talking offline earlier on about the fact that when you talk about savings and reinvesting savings, people immediately assume the only way to make a saving is to cut a service. But actually, there's a huge amount of waste in the system that we're spending money on at the moment. And I think one of the areas that always shocks me is how much money we spend on medicines that aren't taken or aren't needed. Perhaps you could just talk a little bit around that, because there's got to be some money there that if we optimize medicalization or medications, that we could invest in social prescribing.
Yeah, thanks, Gary. Great point. So, I mean, if we look at the literature across the world, actually, around 40 to 50% of patients with long-term conditions like Graham mentioned, hypertension, type 2 diabetes, etc., don't actually take their meds. So 40 to 50% of patients don't take their meds. In England, we spend about 16 billion pounds per annum on medications. Now, assuming that some of those meds are generics and they're a little bit less expensive, we're still looking at least 3 to 4 billion pounds, probably literally flushed down the toilet. And that's our money, that's taxpayer money. So if we're looking at reallocation of healthcare resources, I think that could be, a good starting point. I think in terms of procurement generally, I think we need to come up with better mechanisms whereby we can actually, and maybe other panelists can talk about this as well, see the funding go to the groups and the organizations actually delivering the social prescriptions, because the model, at least in England, that we have right now is the equivalent of, again, if we take a pharmaceutical analogy, we pay for the community pharmacists, but we don't pay the pharmaceutical companies for their pills. That's the current model we have. So we'll pay for the social prescribing link workers in England, but we don't pay the VCSE organizations for the actual social prescriptions that they're delivering. One of the challenges there is actually procurement, because the overheads of trying to procure £3,000 a year for a lunch club that's run by a VCSE organization is just not financially sustainable. But we do need to come up with other mechanisms to do this, because the points that Graham mentioned and Owen mentioned as well, it's and Debbie Ann as well, that this is just not a sustainable model. Okay, thank you. And on that point around the voluntary sector, I'm going to go over to Owen, because I know you're passionate about funding into the voluntary sector, Owen, and that, and along with patient engagement around the possibilities of doing things differently. What do you think about that?
So I think there is a message to patients here, both in terms of wastes of medicines and whether there is a role for social prescribing in terms of getting greater compliance where that is really needed, or actually are there non-prescribing alternatives that could make an impact there. So I think that there is a role in sort of that whole awareness raising of some of these issues with the community. And I think there's also some of the pathways in. Is social prescribing only available if it's prescribed by a GP or a practice nurse, or actually what are the routes in by self-referral? But again, we need that sort of engagement with the community to understand what those pathways are. And I think we do need to see the voluntary community and social enterprise sector as proper partners. I go back to the days in commissioning in the NHS where it was joint planning committees and we'd throw a few crumbs to the sector. I think we have to be realistic now that if we want to see the benefit to society as a whole, that we have to invest in the voluntary and community and social enterprises that we expect to work and help deliver on some of these prescriptions that we're talking about, and to see them as proper partnerships. And I think that's where local integrated care partnerships other ways forward. So having local authorities, CCGs, the voluntary community sector, patient representatives all sitting around the table together and looking, what are the local needs, what are the assets that we have that we can use, and how do we move forward together in that professional relationship?
And again, as we move into the arena of integrated care systems, Owen, what you've just said has got to be at the heart of that for those systems that are going to best achieve and deliver. Unbelievably, we're coming towards the end of the hour already, and I think we've made a really strong case for why this is important, the impact it can have, the importance of research, the importance of training, the importance of engaging patients. John, I'd just like to go back to you quickly, if I may. If someone's out there working in a practice and wants to know how their practice can become more engaged with the RSC about researching sort of social prescribing and improving practice, what's the best way of getting involved?
So they can sign up to the RCGP RSC. Again, if they search that on the internet, it's a simple process to do. And then they could contribute to the Social Prescribing Observatory, and they would also get access to a dashboard so they could look at their individual practice social prescribing activity and benchmark that against what else is going on in England. So yeah, that would be the way to do it, or get in contact with myself or Anand. We'd love to hear from you.
Brilliant. And what we'll do is I'll make sure that we post any links to these things that we've been talking about this evening through our social media channel, so that we can get on there. So, I mean, ultimately going forwards, I think we've seen a huge investment in this recently, certainly in England and across the other 4 nations. And there's a good argument for it. We started tonight with timed introductions from each of you telling me in 30 seconds what your definition of social prescribing is. I want to finish with a bit of an elevator pitch as well, if you could. So for each of you, I'll come round about 30 seconds on, if you were stuck in the lift with someone from the Treasury, what would you tell them about why social prescribing needs funding and what the biggest need is? And I'll start with Graham, if I may, please.
Thanks. I think it was back to the last point, Minister. I think it's really important that you match and sustain the available support in our communities to match the pool of need that is there, and perhaps more importantly, invest to reduce that pool of need in the first place. So please address the social determinants of health.
Brilliant. Thank you very much. The lift doors are just opening and Davina steps in, and you've got your 30 seconds with the Minister.
Hi, Minister. It definitely needs funding because it increases community cohesion, less overprescription of certain drugs. It helps with holistic and personalised care and improves social and economic determinants of health.
Excellent. Thank you very much. And over to John, please.
So I'd have my 30 seconds, but I'd actually ask the Health Minister to come and spend half a day sitting in GP practice to really understand the social need, have his lunch, and then for the second half of the day, he can go out with someone like Debbie Ann, a link worker, and really understand the transformative work they do in empowering people to improve their health and well-being.
Okay, thanks very much. And Anand, how would you chew his ear off and get money out of him or her?
Hi, Minister. 80% of health outcomes of your citizens are due to social determinants of health and social needs. Only 20% are due to clinical factors like hospitals and GPs and pharmaceuticals. And despite this, of the £130 billion that we spend on healthcare, only 2.8% actually goes to some of the 80% of the factors that actually determine your citizens' health outcomes.
Excellent. The only way I could improve on that is call them voters rather than citizens, and I think you'd have it in the bag. Debbie Ann, please.
I would say, hello, Minister. There is a great need amongst your people for support in improving their health outcomes for many, many different reasons and many different factors, including loneliness, social isolation, mental health and other pressing issues. And that's why we need funding for every individual.
Excellent. Thank you, Debbie Ann. And over to you, Owen, please.
Good evening, Minister. Happy and healthy voters are economically active. They form happy communities. Happy communities leads to less public expenditure, and less public expenditure leads to an easier job for you.
Excellent. I don't think I've ever heard such a succinctly argued case before in my life. So the next time he's passing through 30 Euston Square, perhaps we can have a word with the relevant people. That's it for tonight. We've run out of time again. A huge thank you to everybody on the panel. Thank you to everybody who's been watching for the questions you've put in. I think this has been a really fantastic opportunity to tap into the passion and the expertise and the frontline experience of those people that we've had on the panel tonight. I hope those of you watching have enjoyed it as much as I have, having a conversation with these folks. Really look forward to seeing you on the next #Team GP Live event. But that's all for this evening. Thank you ever so much for watching. We'll make sure we get those relevant links posted on social media, and look forward to seeing you the next time. Thank you ever so much. Good night.